Introduction to inflammation. Inflammation is the body's natural defense mechanism against harmful stimuli such as pathogens, damaged cells, or irritants. The purpose of inflammation is threefold: to eliminate the initial cause of cell injury, clear out damaged cells and tissues, and initiate tissue repair. Key components of the inflammatory response include immune cells, blood vessels, and molecular mediators that coordinate the process. While inflammation is essential for healing, it can become problematic when dysregulated, leading to chronic conditions and tissue damage. The inflammatory response is characterized by 5 cardinal signs that have been recognized since ancient times. These 5 signs are redness, heat, swelling, pain, and loss of function. They provide clear physical indicators of inflammation in tissues. The first cardinal sign is redness, or rubor in Latin. This occurs when blood vessels in the affected area dilate, allowing more blood to flow to the site. The increased presence of oxygen-rich red blood cells causes visible redness on the skin surface. The second sign is heat, or calor. The same increased blood flow that causes redness also brings warmth to the area. Additionally, the accelerated metabolic activity of immune cells at the site generates heat, creating a noticeable increase in temperature. The third sign is swelling, or tumor in Latin medical terminology. This occurs when blood vessels become more permeable, allowing plasma fluid and proteins to leak into the surrounding tissues. This fluid accumulation causes the affected area to swell. The fourth sign is pain, or dolor. During inflammation, chemical mediators like prostaglandins and bradykinin directly stimulate pain receptors in the area. Additionally, the increased pressure from swelling puts pressure on nearby nerve endings, further contributing to pain sensation. The fifth and final cardinal sign is loss of function, or functiasa. Pain and swelling naturally limit movement and use of the affected area. This limitation serves a protective purpose, preventing further damage and allowing healing to take place. Together, these 5 cardinal signs, redness, heat, swelling, pain, and loss of function, form the classic clinical picture of inflammation. They represent the body's protective response to injury and infection, serving as visible indicators of the healing process taking place underneath the skin. Acute inflammation is a crucial protective response of the body. Acute inflammation is defined as the initial rapid response to harmful stimuli. These stimuli can include pathogens, damaged cells, or irritants that pose a threat to the body. Acute inflammation has several key characteristics. It has a quick onset, typically occurring within minutes to hours after tissue injury. It also has a short duration, typically lasting for hours to days. Unlike chronic inflammation, acute inflammation is self-limiting and involves a coordinated sequence of events designed to eliminate the harmful stimuli and begin the healing process. The primary purpose of acute inflammation is to deliver defensive elements to the site of injury or infection. These defensive elements include leukocytes and plasma proteins, which create a protective barrier to prevent the spread of infection or damage. This barrier contains the threat while the body initiates the healing process. In summary, acute inflammation is a vital protective response that occurs rapidly after tissue injury, delivering immune cells to create a barrier against further damage and initiate healing. This carefully orchestrated response is essential for maintaining tissue homeostasis and protecting the body from harmful agents. Acute inflammation involves several key cellular players that work together to contain threats and initiate repair. Neutrophils are the first responders, arriving at the site of injury or infection within minutes to hours. They migrate from blood vessels through a process called extravasation. Once at the site, neutrophils phagocytose pathogens and can release neutrophil extracellular traps, or nets. These cells are short-lived and die after fulfilling their purpose. Macrophages follow neutrophils to the site of inflammation. These professional phagocytes engulf pathogens and cellular debris, as shown in this electron micrograph. Macrophages also release cytokines that regulate the inflammatory response. They can differentiate from blood monocytes that migrate into tissues or may reside in tissues as resident macrophages. Mast cells are tissue-resident cells that act as sentinels for the immune system. When activated during inflammation, they degranulate, releasing histamine and other inflammatory mediators. These mediators trigger increased vascular permeability, allowing plasma and immune cells to reach the affected tissue. While essential in the acute inflammatory response, mast cells are also critical players in allergic reactions, as shown in this illustration. Dendritic cells are specialized immune cells that process antigens from pathogens and present them to T cells. This presentation can occur through direct presentation, cross-presentation, or cross-dressing, as illustrated here. Dendritic cells form a crucial bridge between the innate and adaptive immune responses. After capturing antigens at the site of inflammation, they can migrate to lymph nodes to activate T cells, initiating the adaptive immune response. The cellular players in acute inflammation work together through complex signaling networks. Neutrophils arrive first, followed by macrophages, while tissue-resident mast cells and dendritic cells perform their specialized functions. This coordinated response helps eliminate threats and promotes the healing process. Acute inflammation is regulated by various molecular mediators that coordinate the immune response. Cytokines like interleukin-1, interleukin-6, and tumor necrosis factor alpha coordinate immune responses, activating cells and inducing inflammation. Chemokines direct immune cells to the site of injury by creating chemical gradients that cells follow to reach the damaged tissue. Prostaglandins and leukotrienes are lipid mediators that increase vascular permeability, attract immune cells, and are responsible for pain and fever during inflammation. The complement system is a cascade of proteins that enhances phagocytosis and directly kills bacteria through the membrane attack complex. Histamine, released by mast cells, causes vasodilation and increased permeability of blood vessels, leading to redness, warmth, and swelling. These molecular mediators work in concert to orchestrate the acute inflammatory response, from initial trigger to resolution. To summarize, the key molecular mediators of acute inflammation include cytokines, chemokines, lipid mediators, complement proteins, and histamine, each playing essential roles in the inflammatory process. The resolution of acute inflammation is a tightly controlled process that begins once the threat has been eliminated. This resolution phase involves several key components working together to restore tissue homeostasis. Specialized pro-resolving mediators, or SPMs, are crucial for initiating the resolution phase. These include resolvins, protectins, maricins, and lipoxins, all derived from omega-3 fatty acids. Here we can see how DHA, a type of omega-3 fatty acid, is converted to protectins through enzymatic pathways. These protectins play a key role in reducing inflammation and promoting tissue healing. After neutrophils complete their defensive functions, they undergo programmed cell death, or apoptosis. Macrophages then clear these dying neutrophils through a process called efferocytosis. This clearance process prevents neutrophils from releasing their toxic contents, which would cause secondary tissue damage. Anti-inflammatory cytokines play a crucial role in suppressing the inflammatory response. Key anti-inflammatory cytokines include interleukin-10, which inhibits pro-inflammatory cytokine production, transforming growth factor beta, which promotes tissue repair, and interleukin-4, which shifts macrophages to an anti-inflammatory phenotype. The final phase of acute inflammation resolution involves tissue repair and restoration of normal function. This repair process includes removing damaged tissue components, replacing specialized cells, reorganizing the extracellular matrix, and restoring vascular networks. This histological image shows tissue during the resolution phase. We can see inflammatory cells gradually clearing as the tissue begins to repair and return to normal structure. The controlled resolution of acute inflammation is crucial for maintaining tissue health. Proper resolution prevents progression to chronic inflammation, minimizes tissue damage, and restores tissue homeostasis. When this process fails, it can contribute to many chronic inflammatory diseases. Chronic inflammation involves a distinct set of cellular players that differentiate it from acute inflammation. Four major cell types dominate the chronic inflammatory response: macrophages, T lymphocytes, B cells, and fibroblasts. Macrophages become the predominant cell type in chronic inflammation. Unlike neutrophils, which dominate acute inflammation, macrophages persist in tissues for extended periods. Macrophages secrete cytokines and chemokines that perpetuate the inflammatory state, creating a self-sustaining cycle of immune activation. In certain chronic inflammatory conditions like tuberculosis, macrophages form specialized structures called granulomas, which wall off pathogens that cannot be easily eliminated. T lymphocytes play a crucial role in directing immune responses during chronic inflammation. CD4-positive T helper cells coordinate the immune response by releasing cytokines that activate and direct other immune cells. CD8-positive cytotoxic T cells can directly kill infected or damaged cells that may be perpetuating the inflammatory response. T cells and macrophages form a self-sustaining activation loop through cytokine signaling, as shown in this diagram. B cells are specialized lymphocytes that produce antibodies targeting specific antigens present in the chronically inflamed tissue. When activated, B cells differentiate into plasma cells, which secrete large amounts of antibodies that can bind to antigens. B cells also form memory cells, which allow for rapid antibody production if the same antigen is encountered again. In chronic inflammatory conditions, especially autoimmune diseases, antibodies can bind to the body's own tissues, contributing to ongoing damage. Fibroblasts are structural cells that play a significant role in the repair process during chronic inflammation. These cells proliferate in response to ongoing inflammatory signals, becoming activated and producing increased amounts of extracellular matrix components. The excessive deposition of collagen and other matrix proteins leads to fibrosis, or scarring of the tissues. Fibrosis can permanently alter tissue architecture and impair organ function, which is a hallmark outcome of many chronic inflammatory diseases. The cellular profile in chronic inflammation differs significantly from acute inflammation, as shown in this comparison. While acute inflammation is dominated by neutrophils and has a rapid onset and resolution, chronic inflammation features macrophages, lymphocytes, and fibroblasts persisting for months or years. These cells interact in complex networks that sustain the inflammatory state, leading to persistent inflammation, tissue damage, and ultimately fibrosis. Chronic inflammation involves several key molecular drivers that sustain the inflammatory state. These include pro-inflammatory cytokines, reactive oxygen species, growth factors, and transcription factors. Pro-inflammatory cytokines like TNF-alpha, IL-1, and IL-6 are continuously produced in chronic inflammation. These cytokines activate immune cells, mediate the acute phase response, and stimulate the production of more inflammatory mediators, creating a self-sustaining cycle. Reactive oxygen species, or ROS, cause ongoing oxidative stress and tissue damage. These molecules damage DNA, proteins, and cell membranes, amplifying inflammation and promoting tissue destruction. Growth factors like TGF-beta, PDGF, and VEGF are continuously released during chronic inflammation. These factors stimulate tissue remodeling, fibrosis, and the formation of new blood vessels, contributing to the ongoing inflammatory process. One of the most critical transcription factors in chronic inflammation is NF-kappa B. NF-kappa B regulates the expression of numerous genes involved in inflammation, including cytokines, chemokines, adhesion molecules, and enzymes. In chronic inflammation, NF-kappa B remains persistently activated through both canonical and non-canonical pathways. This creates a self-sustaining cycle where NF-kappa B activates genes that produce more inflammatory mediators, which in turn activate more NF-kappa B. These molecular drivers interact to create a self-sustaining cycle of chronic inflammation. Cytokines activate NF-kappa B, which drives inflammatory gene expression. This produces more cytokines and reactive oxygen species, perpetuating the cycle. In chronic inflammation, persistent inflammatory processes lead to significant tissue remodeling. Pers- Persistent inflammation causes ongoing tissue destruction through several mechanisms. Proteolytic enzymes released by inflammatory cells break down proteins in the tissue. Reactive oxygen species cause oxidative damage to cells, and the continuous recruitment of immune cells perpetuates the destructive cycle. At the same time, repair mechanisms attempt to heal the damage. Fibroblasts are activated and produce collagen to repair the tissue. However, this often leads to excessive collagen deposition, a process known as fibrosis. Normal functional tissue is gradually replaced with dense, fibrotic scar tissue. Chronic inflammation creates a delicate balance between ongoing tissue destruction and attempted repair. This balance determines the extent of tissue remodeling. When inflammatory cells and cytokines promoting damage outweigh those promoting regeneration, tissue damage predominates. The ultimate consequence of tissue remodeling in chronic inflammation is altered tissue architecture and compromised function of the affected organ. This can lead to progressive tissue damage and potentially permanent dysfunction. Common examples include pulmonary fibrosis in the lungs, cirrhosis in the liver, and glomerulosclerosis in the kidneys, all leading to impaired organ function. Acute inflammation can be triggered by various factors. Microbial infections from bacteria, viruses, or fungi activate the immune system through pattern recognition receptors like toll-like receptors. Physical trauma damages tissues and releases danger signals called DAMPs, or damage-associated molecular patterns. These signals trigger neutrophil recruitment and inflammatory cascades. Chemical irritants such as acids, alkalis, or toxins directly injure tissue cells. This leads to the release of inflammatory mediators like histamine and cytokines from damaged cells. Thermal injuries from extreme heat or cold cause tissue damage through different mechanisms. Heat causes protein denaturation and cell death, while cold leads to ice crystal formation and vascular damage, as seen in frostbite. Foreign bodies like splinters or dirt provoke inflammatory responses. These responses aim to isolate and expel the objects through processes like granuloma formation and fibrous encapsulation. Allergic reactions trigger inflammation through antibody-mediated mechanisms. This typically involves IgE antibodies binding to mast cells, leading to degranulation and release of inflammatory mediators like histamine. Acute inflammation produces several systemic effects that extend beyond the local site of injury or infection. One major systemic effect is leukocytosis, an increase in white blood cell production. The bone marrow releases more white blood cells into circulation to meet the increased demand for immune cells. Neutrophils often predominate in the early stages of acute inflammation. Fever is another key systemic effect. Inflammatory cytokines like IL-1, IL-6, and TNF-alpha act on the hypothalamus to reset the body's temperature regulation. This results in an elevated body temperature, which creates a hostile environment for pathogens and accelerates immune responses. The liver produces acute phase proteins in response to inflammatory cytokines, particularly IL-6. These include C-reactive protein, fibrinogen, and serum amyloid A. These proteins enhance immune responses, promote complement activation, and serve as valuable clinical markers of inflammation. Fatigue and malaise are common during acute inflammation as the body redirects energy to immune functions. Inflammatory cytokines act on the brain to promote rest and recovery, reducing energy available for non-essential activities. This explains why we often feel tired and unwell during infections. All these systemic effects work together to coordinate the body's defense against threats. They help prioritize immune functions, prepare the body for potential escalation of the threat, and signal the severity of the challenge. This coordinated response increases the efficiency of the body's defense mechanisms.
Chronic inflammation produces widespread systemic effects throughout the body. These effects impact multiple organ systems, including cardiovascular, metabolic, hematologic, muscular, and neurological systems. Chronic inflammation begins at the cellular level and progresses to affect tissues, eventually causing system-wide alterations throughout the body. Persistent, low-grade inflammation contributes significantly to atherosclerosis and cardiovascular disease. Inflammatory cytokines encourage plaque formation in arteries and promote thrombosis. Insulin resistance and metabolic dysfunction develop as inflammatory mediators interfere with insulin signaling. This can potentially lead to type 2 diabetes and other metabolic disorders. Anemia of chronic disease occurs due to altered iron metabolism. Inflammatory cytokines increase hepcidin production, which reduces iron availability to bone marrow and impairs red blood cell production. Muscle wasting, or cachexia, results from prolonged exposure to inflammatory cytokines like TNF-alpha and IL-6. These cytokines increase protein breakdown and reduce protein synthesis, leading to loss of muscle mass and strength. Fatigue and depression manifest from neuroimmune interactions. Inflammatory mediators can affect the brain through humoral and neural pathways, altering neurotransmission and hormonal balance. These systemic effects of chronic inflammation significantly impact quality of life and overall health. When multiple body systems are simultaneously affected, a cycle of worsening health can develop, making early intervention crucial.
Inflammation in metabolic disorders represents a unique relationship between our immune system and metabolism. Metabolic disorders like obesity and type 2 diabetes are characterized by chronic low-grade inflammation, a state fundamentally different from acute inflammatory responses. This chronic low-grade inflammation in metabolic disorders has been termed metaflammation, metabolic inflammation. Adipose tissue plays a central role in this inflammatory process. In obesity, adipose tissue undergoes dramatic changes. Normal fat contains anti-inflammatory cells like M2 macrophages, while obese fat accumulates pro-inflammatory cells, including M1 macrophages and neutrophils. Obese adipose tissue secretes pro-inflammatory molecules called adipokines and attracts immune cells, particularly macrophages. These changes transform fat from a storage organ into an endocrine organ, driving inflammation. This inflammatory state contributes to insulin resistance, a hallmark of type 2 diabetes. Normally, insulin binds to its receptor and initiates a signaling cascade that promotes glucose uptake. However, inflammatory mediators like TNF-alpha and IL-6 interfere with this insulin signaling pathway, blocking the transmission of signals and preventing proper glucose metabolism. This creates a vicious cycle where inflammation leads to insulin resistance. Insulin resistance causes further metabolic dysfunction, which promotes adipose tissue expansion and dysfunction. This dysfunctional adipose tissue then produces more inflammatory mediators, completing and perpetuating the cycle. This inflammatory state contributes to multiple complications beyond diabetes. Non-alcoholic fatty liver disease is a common complication. Here we see how inflammation, obesity, and insulin resistance can progress from a healthy liver to non-alcoholic steatohepatitis, or NASH. Other complications of this metabolic inflammation include atherosclerosis, endothelial dysfunction, and worsening systemic insulin resistance, creating a multi-system disorder. Understanding this connection between inflammation and metabolism offers potential therapeutic targets for treating metabolic disorders. Lifestyle modifications can significantly impact inflammation levels. Anti-inflammatory diets rich in fruits, vegetables, and antioxidants can reduce key inflammatory markers. Omega-3 fatty acids are particularly important as they inhibit inflammatory pathways in the body. Regular physical activity has powerful anti-inflammatory effects through multiple mechanisms. Adequate sleep is essential for proper immune regulation. Sleep disruption increases inflammatory markers. Stress management techniques like meditation reduce stress hormones that promote inflammation. Maintaining a healthy weight prevents excess adipose tissue inflammation. Even modest weight loss can reduce inflammatory markers. These lifestyle approaches complement medical treatments and may help prevent inflammation related diseases. Inflammation represents a double edged sword in human health, with both beneficial and harmful aspects depending on context and duration. Acute inflammation is essential for survival. When the body encounters pathogens or injury, it mobilizes immune cells to the affected area. These cells eliminate threats through processes like phagocytosis and initiate tissue repair. However, when inflammation becomes chronic, it contributes to numerous diseases. Persistent inflammation is associated with cardiovascular disease, neurodegeneration, autoimmune conditions, and even cancer. It also accelerates the aging process. Understanding the balance between beneficial and harmful inflammation is crucial. The immune system constantly regulates pro-inflammatory and anti-inflammatory responses. Too much in either direction can lead to problems, either insufficient protection or excessive damage. Modern medicine aims to harness inflammation's benefits while minimizing its destructive potential. By targeting specific inflammatory pathways while preserving essential immune functions, treatments can be developed that manage inflammation more precisely. This approach represents the future of inflammation research and therapeutic interventions. In conclusion, inflammation is both our protector and, when dysregulated, our adversary. The key to health lies in maintaining its delicate balance.
If you enjoyed this video and would like to practice your understanding, go to matheasy.com. There, you'll find this lesson outlined and divided, with a short quiz to see how well you really understood it. And if you're hungry for more, we've got piles of other topics for you to explore. Start learning easier. Visit Matheasy today.